What about another one of those comorbidities, gastroesophageal reflux disease? This is a study by Ganesh Raghu published a couple of years ago. He took a look at 65 patients with IPF. 46 had no reflux therapy, and then he put down a pH probe, which is a monitor for the acidity in the esophagus, just above the lower esophageal sphincter and above high. And the pH probe was positive in 87%. That's pretty high. What's really interesting is he took a look at those that were on therapy. 63% still had a positive pH probe. So something's going on here. We just haven't figured out what. This is an abstract we presented at ATS this last year, where we took a retrospective look at our charts and defined GERD as symptoms or symptoms as a narrow definition and then a broad definition to include those that were on proton pump inhibitors or other medications. And there were two really interesting findings here. First of all, the rate of GERD was pretty high. But I think the other interesting aspect was that the rate of diabetes and hypothyroidism was also high. Now, some of that's an age-related issue. We know that those diseases go up with age. But our rate was actually much higher. I think our order of magnitude was about 3 times higher for hypothyroidism than an equivalent population. And so one has to wonder, as I said, if there's more of a systemic disease going on. And again, more comorbidities that need to be monitored and taken care of. I picked this one because the slide was already made for me, but Hal Collard and I both did the same study. It had somewhat similar results, and we're teaming up to try to move it along further. Hal took a look at 85 patients and took a look at the CT scan as to whether or not a hiatal hernia was present. You see, as we age, the rate of hiatal hernia goes up. And if you have a hiatal hernia, the lower esophageal sphincter relaxes. It can't squeeze as much because it's in the wrong place. And that creates a reservoir of material for aspiration, which would increase the reflux. And it's not difficult to imagine that if a patient is refluxing or microaspirating, that could be a measure of injury trigger to the airway, like smoking or other environmental exposure, that could be triggering this whole process. And indeed, he saw an incredibly high rate in his group. We were closer to about 68%. He was 96. Basically, you can quickly appreciate that the radiologist doesn't have a whole lot of difficulty in reading the presence of those hiatal hernias. And that's even the 68% is much, much higher than equivalent aged groups. So to kind of wrap those up, on the cardiovascular side, a much higher rate of coronary artery disease in these patients, obstructive sleep apnea is much higher, pulmonary hypertension is much higher, reflux is much higher, and I think has a lot to be worked out. Another comorbidity that I didn't show you data on, but clearly needs to be addressed in terms of the quality of life of patients with IPF is cough. I mean, it's the #1 reason they come in, it's the #1 reason they get diagnosed, and one of the major problems in terms of the quality of their lives. And so trying to make them understand what's involved with the cough, how important the cough is or is not, and then trying to address it can be a very important thing to the quality of someone's life. And then depression. You know, all patients with chronic lung diseases, all patients with chronic illness have higher rates of depression. And we want to make sure that the quality of life is maintained as good as we can. I saw we have a whole session on pulmonary rehab, but I'm going to touch on just a couple of points, which were 2 recent studies. One took a look at 99 subjects in an observational pre- and post study that took a look at 6-minute walk difference from baseline with a pretty good improvement of 56 meters and an improvement in shortness of breath. And I'm going to bring this up because I want to show you the other side, which was the pulmonary rehab in 57 patients, 2 sessions a week, 30-minute endurance exercise, upper limb endurance and lower limb endurance. And the outcomes at 8 weeks, again, were positive. And some have touted this as being a negative study because when the patients stopped, they lost the effect. Well, to me, that just makes sense. I'm not expecting exercise to work miracles if you don't keep it up. That's true for all of us. This is a diagram of what that study basically showed. Basically, if the patient exercises, their 6-minute walk distance goes up. And one of the parameters I showed you earlier is a distance saturation product. So if you can better condition an IPF patient, they will probably do better overall. What they cannot do is do the exercise program and then hang it up, because they're going to regress. But that's true of all of us. I always joke, pulmonary rehab's actually, what it really means is exercise for us all, right? Don't be a couch potato. The more we move, the more we do, the better we do. And I think this is just an example of that. So I want to encourage rehab, and I'm very excited to hear what that rehab session has to say. I'm going to touch on exacerbations mostly as a prognostic issue. Dr. Johnson did a nice job addressing some of it. And indeed, there's that same slide. This is where the concept kind of came out, that, you know, the drop in these patients probably isn't linear. There's probably this stepwise exercise, and some of that may be from these exacerbations. Now, that's a tricky business, and I'll tell you why. These exacerbations are highly mortal. We know that a great number of patients who get an exacerbation don't survive. Their survivorship is under a month. But if they survive, what you see is a drop in the level of function without recovery of that function. And so they maintain themselves, and the mortality rate goes up dramatically. Now, why do I want to address this? I want to address it because, again, it becomes a comorbidity that you want to take a look at. This is just showing you that diffuse alveolar damage with this hyaline membrane disease on top of a pattern of UIP. And this is directly out of the paper that Jim and I participated in with Hal Collard as a suggestion for the definition of an acute exacerbation. And this demonstrates what you see on the CT scan in these patients. You start out with a UIP pattern with this honeycombing, and what you get is the overlap of ground glass on top or that diffuse alveolar damage in the acute event. So what's the working definition? Unexplained shortness of breath over 30 days, new CT scan changes with no evidence of infection either by endotracheal aspirate or bronchoalveolar lavage, and exclusion of alternative causes, no heart failure, pulmonary embolism, or other reason for acute lung injury. And so what that means is if a patient presents with an exacerbation, while I don't have evidence for how to treat it, I do have evidence for how to treat the other elements that can mimic it, right? If there's an infection, we want to know. If there's aspiration, we want to take care of it. If there's an MI, we certainly have a lot of therapies. Pulmonary embolism, again, can be treated. Pneumothorax is not uncommon in these patients. Congestive heart failure, and finally, idiopathic is really where the exacerbation data falls in. What's the frequency of these exacerbations? It's an interesting thing. I'll tell you that this literature is born out of Japanese literature. And for whatever reason, it's dramatically higher in the Japanese than it is in the US populations or the European populations. And this slide really demonstrates that. The Azuma and Kubo papers demonstrate exacerbation rates of between 18 and 22%, whereas the American studies are closer to under 5% per year. Now, there's a lot of conjecture over why that is, and probably a lot of factors that go into it, but it is something that we still need to iron out. So we want to exclude other diagnoses. A high-resolution CT scan is probably really important in these patients, maybe with or without a spiral CT scan. Bronchoscopy, if the medical status allows you to do it. We usually treat with broad-spectrum antibiotics and corticosteroids, and as Dr. Johnson pointed out, it's unproven. I will tell you anecdotally, I've thrown anticoagulation at these patients as well from the get-go. And the last patient I had who exacerbated, which was about 6 weeks ago, did something very dramatic in my view. He did not survive. We listed him acutely for transplant. He went on for about 16 days, actually without anything really happening on a ventilator, and then finally succumbed, I think, to a line sepsis. But he just kind of held his own with supportive care. It was really quite dramatic, because usually most of them I've seen just kind of have that terminal event.